This is Nubia Ramirez speaking, and today I will be giving you an introduction to neurodevelopmental disabilities. From here forward, I will be referring to neurodevelopmental disabilities as NDDs. First, I'm going to introduce myself, then I'm going to tell you about my educational associations, so you know why I'm here today, and then I'm going to go ahead and do the presentation of the material. Unfortunately, because this is not a synchronous presentation, we will not have the opportunity of doing a Q&A session at the end, but I hope to have covered all of the material that might help you with some of the questions that come across. So this is me. My pronouns are she, her, ella. I moved from Mexico to Alaska in 2014, and about a year and a half later, I moved to California, and I have been here ever since. I went to Universidad de Guadalajara for my undergraduate studies in nutrition. I am the youngest of two daughters, and I am currently a social work graduate student of Sacramento State University and a LEND trainee. And in a few more minutes, I will be telling you a little bit about LEND so that you know about this program. Well, the way that I was introduced or exposed to the world or to the community with NDDs is because there are two of my family members who live with NDDs. One of them has Down syndrome and the other one has autism. And also before starting my graduate education, I worked for a day program for adults with intellectual and developmental disabilities. And through my education to become a social worker, I started an internship with UC Davis Mind Institute. So I'm going to give you a little bit of background information about the Mind Institute. So it was founded in the year of 1998. It was built for families by families of people living with NDDs. And it's a collaborative international research center that is committed to the awareness, understanding, prevention, and treatment of the challenges associated with NDDs. And the vision for the creation of this institute was to bring experts working together toward finding and developing treatments to reduce the challenges and to improve the quality of life for individuals with NDDs and also for their families. And through my internship with UC Davis Mind Institute, I was offered the opportunity of applying for the LEND training program. The word LEND itself stands for Leadership Education in Neurodevelopmental and Related Disabilities. It is a program that extends through 44 states in the US, and it has 52 LEND programs. And as I mentioned, it's a training program that is for clinicians, for family members, for persons with disabilities who are oftentimes self-advocates, and also for policymakers. And the way that the program is structured is with three main components. So a third of our time, we use it in seminars. So we have people who have an area of specialty in NDDs come and tell us their information, new research studies and findings, and all of the basic information that we should know to identify NDDs. The other third of our time, we use it for clinical placements. For example, me as a social worker, I have had the opportunity of interacting with families one-on-one, doing social assessments, seeing any other needs that the families might have, and make referrals to connect them to community resources. And the last third of our time, we use it for community placements. For example, for my community placements, this is one of my activities that I conduct at times, which are doing presentations in the community and with different institutions. So LEND provides high quality education that emphasizes the coordination of services for families, and it's focused on diversity, partnership, and care centered around families and whatever is the most important for families. And the goals for the LEND program's partnership with institutions such as Oak Park is to build partnerships with staff, to provide good quality information, to support referrals, which I will be discussing later during this presentation, and also to meet the goals and the needs of different places. This is a good time. If you're watching this presentation by yourself, you can pause the video and think about these questions that I have posted in this slide. So what do I know about NDDs? What experiences have I had? What questions have come up to me about NDDs? If you are in a group setting, you can pause the presentation and share with your colleagues to have an idea of what other people have experienced and also to make a more enriching conversation around NDDs. And well, you might ask yourself, why am I learning about NDDs? The CDC, which are the Centers for Disease Control and Prevention, estimate that 1 in 6 children in the US live with one or more developmental disabilities, which talks about the relevance or being aware about this topic and how prevalent it is in our communities. I also found a study that compared 2 year groups. So from 2009 to 2011, and those 2 years got compared to 2015 through 2017, and they found a significant increase in the prevalence of NDDs, ADHD, and autism. And this can mean that either there are more cases of NDDs that are rising as the years go by, or we are getting better at identifying them and diagnosing them as a society, as a community, and also around the healthcare providers. You are also learning about NDDs because teachers can help identify children who might have NDDs and make referrals for testing. And I will talk about the relevance about this later on during this presentation as well. So I know a few weeks ago you had a presentation on NDDs and trauma and how to differentiate between one or the other. So this is a reminder about what NDDs are. So these are disorders that impact the way that the brain works. They range from mild to severely disabling, and this is on a personal level from whatever NDD that the person has, and also for their level of functionality. And I'm going to be touching on this later on during the presentation as well. And the most common NDDs that we find in preschoolers are autism and also ADHD. So I wanted to add the topic of language within the world of NDDs because it's very relevant and language matters. We know that words have power. Words can make us feel bad, can make us feel better, can impact our mental health. So the way that we use our words has to be responsible, especially around topics that are oftentimes delicate. And the way that we use our language and our words, we want to move it more towards a sense of belonging, for it to have diversity included in it, and also to reflect inclusion as a society and as a community. During the next slide, I will be telling you about what person-first language is and why it matters, especially in the world of NDDs. Historically, language referring to people with disabilities has been used in offensive ways. So now we are trying to do progress towards a more respectful and inclusive word choice. And this is what I was referring to in the last slide. So person-first language puts the person before the disability and describes what a person has, not who a person is. So to make a little bit more clear how to use person-first language, I have these few examples of outdated versus respectful terminology. So some terms that we want to stay away from is, for example, saying this person is afflicted with a disability, is suffering from a disability. And the reason why we want to stay away from expressing these words is because, especially the word afflicted or the word suffering, puts this in a negative context, and we want to stay away from that. Also, we don't want to use the term the disabled. We don't want to express or refer to the people living with a disability as handicapped, invalid, mentally ill, so on and so forth. And moving towards a more appropriate word choice, we want to say person with disability, person with a mental health condition. We also want to refer to them as a person that has autism, as a person that has a disability, a cognitive disability. For example, given my name as an example, we would like to say Nubia has autism, Nubia has a disability, Nubia has a cognitive disability, so on and so forth. And instead of using words such as handicapped, we would use or replace that word with accessible. So instead of saying that's a handicapped bathroom, that's a handicapped bus, we would say that is an accessible bathroom, that is an accessible parking spot. And instead of saying wheelchair users, we would say that is a person who uses a wheelchair, that is a person who uses a mobility chair. And these are some of the acronyms that are used in the community with NDDs. I added the website from which I took these acronyms from. So if you're interested in learning more about them or how they came about, how they're used, please feel free to visit this website. So some of the acronyms that you might already be familiar with are ADHD, for example, which stands for Attention Deficit Hyperactivity Disorder. Another one is ASD, which stands for Autism Spectrum Disorder. And we commonly refer to autism spectrum disorder only as autism. There's other ones, for example, some therapies such as PT, which stands for physical therapy, or OT, which stands for occupational therapy. And one of these acronyms that I want to bring to light, and maybe you have already heard about, it's IEP, which stands for Individualized Education Plan. And this is especially relevant to be aware of and to feel familiarized with, because the children with NDDs, as they continue on with their education, the whole team that takes care of them, that's in contact with them, comes together to build a plan to help that child achieve their goals. And this is, again, very specialized only is personalized to the student that is in question. And it helps the student reach the educational goals that are wanted, and also for overall educational success. The causes for NDDs are still largely unknown, but some things that have been thought about are low birth weight, premature birth, also some environmental contaminants or toxins, for example, exposure to lead. NDDs may also run in families, so that tells us about a genetic component to them. And also they could be due to fetal exposure to medications or substances. And the severity of disability that each person experiences is going to dictate the level of support that each person needs. And this will lie within a spectrum. Some people will have strengths in some areas, and some people will have needs on those exact areas. So it all lies within a spectrum. So children may require support with communication, with socialization, with learning, with emotional or behavioral regulation, and also carrying out daily living activities such as eating, brushing teeth, showering, using the restroom, walking, etc. Very important to keep in mind that each child is unique, and the same condition can look different in various children. So these are the most common NDDs, which are ADHD, autism, vision impairments, learning disabilities, intellectual disabilities, conduct disorders, cerebral palsy, and hearing impairments. And since this presentation is only an introduction to the NDDs, I will go over very basic information about the most common NDDs. So starting off with attention deficit hyperactivity disorder, or ADHD. So the children who have ADHD might experience challenges in attention, in the ability to stay still, and also in self-control. Some of the signs that could tell you that the kid might have ADHD is that the kid might be fidgety, restless, and easily bored. They may also have trouble sitting down or staying quiet, especially when they are in environments when they are expected to stay quiet. They might rush through things and make careless mistakes. And for this, it is important to highlight that this is not something that the kids have control over, and this is not something that they make intentionally. They might also climb or jump when they shouldn't, or when they are asked not to. They might be impulsive, have low frustration tolerance. They may have lower than expected attention span, as expected for their age. They may have issues staying on task, and might be seen often fighting with peers, and these might be related or due to the low frustration tolerance that they have. Something very important to do is to distinguish between the expected behavior for age and behavior that goes beyond that and needs to be explored further or addressed. So here you want to look for children who are really struggling, children that are not able to abide by the rules, or that you have tried to redirect several times and they are still having difficulty or challenges. So how can you support students with ADHD in the classroom? One tip is to assign seats and to create a welcoming space. For example, adding plants around the classroom, hanging pictures or art that they do themselves, have a couch in one corner, etc. So just anything that would make the environment more warm and more welcoming for the children. Also, you can allow students with ADHD to self-regulate. For example, if you see one student having a very challenging day, you can maybe give them a ball that they can squish in between their hands, and that's going to help them with the regulation. You can also always give behavior-specific praise. For example, you can tell them, excellent work, waiting for your turn to talk, or great job staying on your seat until I dismiss you from class. You can also implement a reward system or a daily report card that encourages positive behavior and discourages unwanted behavior. And with this is suggested that you use visuals. So instead of writing a lot of words, just having some pictures, because at this age, they are very good with picking up visual information. And also it's like for everybody is information that we can digest or absorb more quickly if it's visually presented to us. And also you can be consistent with in applying rules in the classroom. That also helps students with ADHD. So moving on to autism. This is a neurodevelopmental disorder that impacts communication, social interaction, and results in restrictive and repetitive behaviors. So what can autism look like in children? So the children might not respond to their name after you call them. They might avoid making eye contact. They might not smile back at you when you smile at them. They may get very upset if they do not like a certain taste, a certain smell, a certain sound. And something that is important to think about here is that usually the way that they express being upset might be a little bit stronger than the other children. They also have repetitive movements, for example, hand flapping or flickering of the fingers or rocking their body back and forth. And this is something that they do often. They might also not talk as much as the other children, or they may repeat the same phrases over and over again. And I wanted to add this image because I think it does a good job explaining the different levels of functionality within autism. And before I go into this, I would like to just mention that autism spectrum disorder, as the name itself says, is in a spectrum. So even though here it has 3 different levels of functionality, we have to think of everything within autism as in a spectrum. So the level 1 of ASD is the one that is less disabling per se. So they might, people in this or children in this level of functionality might have difficulty initiating social interactions, and organization and planning problems can hamper their independence. For level 2, they require substantial support. So the social interactions are limited to narrow special interest. So for example, if there is a child that has a special interest in toys, in toy cars, they might only want to play with other children if the other children are playing with toy cars. But then if the other children are playing with anything else, they're just not interested in engaging play with those children. They also might have frequent restricted or repetitive behaviors, like I mentioned in the last slide, so that hand flapping or flickering of the fingers. In level 3, they require very substantial support. They have severe deficits in verbal and nonverbal social communication skills. They might have or might show great distress or difficulty changing actions or focus. So this difficulty changing actions or focus might make them feel overstimulated. For example, if there's a change in activity, also part of their distress, not only with changing the activity, but the part of them having severe deficit in communication. So, for example, let's say that a kid is hungry or thirsty, they feel tired, they feel too hot, but they don't have a way of telling you with words, and they are not able to express through their facial expressions or facial gestures. And if the people around them is not picking up on whatever need they might have at the moment, this is something that can cause them a lot of distress and might trigger some meltdowns in them as well. So what can be done in the classroom to support students with ASD? So you can encourage naturalistic play therapy. You can let the children pick the toys that they feel more, that they gravitate more towards, and you can allow them to be in whatever spot in the classroom where they feel more comfortable. You can also try to manage sensory challenges, so loud noises, which of course, because of the age group that you work with, is sometimes challenging. But if there's anything within your power that you can do to manage any sensory challenges, is highly encouraged. You can also have some sensory toys or sensory books that you can have around the children can use. You can support desired behavior. Oh, that's always a good idea. And also support communication, especially with the children who are in the third level of functioning within ASD. For example, if you want to support communication with drinking, you would show them with your body, like you would put your hands in front of your chest and then lift your hand from your chest to your mouth and do that motion back and forth and say drink, so that they understand that that means drink. And potentially even that's something that they could model in the future, so that they would be able to tell you when they are thirsty. Also, to prevent challenging behaviors, you can use consistent daily schedules. So again, using visuals is very important. And you can have, for example, the consistent schedule saying like at 9 a.m., we're all going to have a snack, and put a little picture of a snack on the side. And then at 9:30 is nap time, so on and so forth, and just keep it consistent throughout the days. You can also give them transition warnings, and this is more so that students or the children prepare themselves for the transition to different activities that they're going to experience. So you can tell them, for example, oh, in 1 minute or in 2 minutes, we're going to go from, I don't know, from circle time to coloring, or from coloring to numbers or such. But just telling them what's next, and in how many minutes the activity is gonna change. Also, to give children a sense of control, you can offer choices so they have a say in the situation. As I've mentioned a couple times by now, just catch them being good, and praise them whenever it is adequate and you think that it would encourage them a little bit more. So moving on to visual and hearing impairments, this is pretty straightforward. With either visual or hearing impairments, most children will use devices that are corrective, that are adaptive, that will help them interact with their environment around them. So children might have glasses, might have hearing aids, but the most important component to consider here is the need for classroom accommodation. And this can be having the child with a visual or a hearing impairment closer to the front of the classroom, for example, so that they can see you better, they can see whatever you are showing to the classroom better, or they can even hear you better. And moving on to learning disabilities, these are some signs that can tell you, or might give you an idea that maybe a student could be potentially facing some learning disabilities, is that they're late talking as compared to other children. and children in their same age. They might have pronunciation problems, they might have slow vocabulary growth, or they might be unable to find the right word that they want to use or in the correct context. They might have difficulty rhyming words, trouble learning numbers, alphabet, days of the week, things that children in their age group are already learning. They might be or seem extremely restless and easily distracted. They might have trouble interacting with other peers, or also might have poor ability to follow directions or routines. So maybe if you identify these signs on your students, you might want to think about, is it necessary, or would I want to talk to somebody about these concerns? Would I want to see into what's next? If I should be referring the student to an evaluation, talking to the parent, so on and so forth, to just support the student success. So within the world or the community with NDDs, education is free and appropriate for all students. I wanted to mention the IEP earlier today so that I could go a little bit more in detail in this slide. So within the IEP, which I mentioned is pretty much a action program per se for the student, which will include all of the goals for this specific student with the specific needs that they have. It will also say what are the therapies or the special accommodations that are going to be done for this student so that their education is actually appropriate. I would also like to add that for students with NDDs, what is most encouraged is to have the least restrictive environment. So they try to have the children be around children who are developing as we expect as much of the time as they can, and only if there's like a specific therapy or need that cannot be met in that classroom is when the child would be taken to a special setting or environment. So the IEP can include information about special education, how many minutes a week or how many times a week it'll take place. Also, that the same is true for therapy such as speech and language, how many times a week, on which setting these therapies are going to take place, also occupational or physical therapy, and also other services such as psychology or counseling services. So the importance of identifying and referring the students to evaluations and assessments will eventually get them connected to services. And early intervention services can change a child's development and developmental path and improve their outcomes for the children, for the families, for the communities, and also for the way of how the child adapts to the present, but also helps in their future adult life. So moving on to cerebral palsy, this is also for the most part pretty straightforward. So cerebral palsy is a group of disorders that affect a person's ability to move and to maintain balance and posture. So we can see oftentimes children or people with CP use a wheelchair or any other device that helps them move around. And also the same as with hearing and visual impairments, with cerebral palsy, the most important component to consider is the need for classroom accommodations. So probably to have these children seated more close to the exit or entrance area of the classroom, that might be helpful or beneficial to them. Moving on to conduct disorders, again, referring back to the presentation that you had earlier about the difference between NDDs and trauma, maybe you can think of that presentation and how it applies to conduct disorders or how it connects. So conduct disorders can develop from brain damage, from trauma, from child abuse, child neglect. So the children experiencing conduct disorders may have repetitive behavioral and emotional issues. They may have issues with self-regulation. You might see them engaging in fights with other students, having lower tolerance and having more meltdowns. You can maybe see them crying more often than other children. And you as a teacher, the one thing that you have to just keep in mind and consider more is these children's need for understanding and guidance as well. So your involvement matters. Teachers know each one of their students. All of the time that you spend together makes you know them as individuals, as persons. Teachers are also a key element in the children's success. And for many conditions, an early diagnosis of NDDs will pave the way for a better prognosis. And this is why we make such an important emphasis on learning about how to identify red flags and talk to parents and make referrals or talk about referrals with the appropriate people as appropriate, so that you can potentiate or help with the development or the success of these children in the present and also for their future life. So what to do if you have concerns about a child? The first thing that you can do is talk to the parent or the parents. They know their child best, and especially if they have other children who are older than this child in question, they might be able to tell or make a comparison on how one of their child is developing versus the other. And that might make them kind of think about, maybe, is this something that I should look more into? Or sometimes parents already have their concerns. And if a teacher or somebody else that is around the child brings this topic up to their attention, maybe that will reassure them that they do need to take care of it. That it's more people around them also that are noticing this, not only them, or even empower them to take the matters into their own hands and do something to move forward with this. So you can also refer the child to the school district for assessments. And for those assessments, you can ask, especially if you think that this child might have a learning disability, for example, you can tell them, so the assessment is because I think this might be an NDD or possibly a red flag for this. And you can also discuss referrals to pediatricians with parents. In the next slide, I will tell you about resources that can help you with, or can help the parent with the referral for assessments or further evaluations for the children. The Help Me Grow resource, it's a local resource that has some tools that can help you with the referral process. And also all of the information that we share with these presentations or the list of different local resources, please feel free to share them with families, with parents, or any other people that you think might benefit from them. So these are a couple of helpful resources to identifying and referring for NDDs. So Help Me Grow Sacramento, I added the link to the website. It supports children from birth to 5-year-olds. It connects children to developmental screening and service providers. The website has some learning activities that teachers can use with the children, or parents even can use with the children, and also has some other resources for readiness for school and other family resources. What I was mentioning about the tools, it has, for example, like milestone trackers that you can use to support the referrals. Also, the CDC created Learn the Signs, Act Early. I added the website for them as well. It has tools for tracking growth milestones as well. So here they categorize in different age or stages of development. For example, 0 to 3 months, 3 to 6 months, so on and so forth. And in these tracking milestones tools, they say at this specific stage, what is the child expected to do? And then either the parent or the teacher can say, yes, the child is doing this. No, the child is not doing that. So that this might give you a guidance on what is expected for that stage in the development, and what is being met and what is not. So it has free printable materials. It has a lot of training resources. It also has tips to act when there are developmental concerns, and just information about other programs. So here's a list of other helpful helpful online resources. This presentation is going to be made available to you as a recording and also as a PDF document. So all of these resources are something that you can come back to and look over. If you're interested in learning more about something in specific, maybe you want to visit any of these websites. For example, if you want to learn a little bit more about resources for ADHD, I added the chat website right there. And then right about at the middle of the slide, I also added a very great local resource, which is the Wormline Family Resource Center. Other resources that can be very beneficial if you want to just learn more about this, or also find resources for yourself, or to just share with loved ones or family of the people that you work with. And I just want to finalize this presentation by thanking you all for everything that you do for your students. You are truly a key element in their development and in their progress and in how they are shaped as individuals since they are very little. So thank you all for all of your hard work. And here I added the information for the UC Davis Mind Institute, the address, mainline, and also the direct line to the Macy Family Clinic, which is the one that takes care of developmental evaluations. And I thank you all for this time and listening to this presentation. I hope you can keep something about learning about this presentation, that you learned something maybe that you didn't know before. Thank you so much. I hope you enjoy the rest of your day.
The UC Davis Mind Institute was founded in 1998 with the promise to reduce and prevent the disabilities that can be associated with autism and other neurodevelopmental conditions. Every day, our clinicians and researchers make progress on that promise. Our groundbreaking research on autism, Fragile X syndrome, chromosome 22q11.2 deletion syndrome, ADHD, and other conditions associated with disability are helping affected individuals achieve their fullest potential. Please visit our website or our social media platforms to find out more about current studies, upcoming events, and how you can help make a difference.